I am Dr. Robin Bates. I am a University Research Fellow, and it's my pleasure to welcome you here today. Before I introduce our speakers today, I want to make sure that everyone knows about the Research Center's next writing initiative. It's the 7K in 2 weeks. It's a 2-week writing marathon with a daily goal, and you can sign up, enter your daily writing amount, and should end up with 7,000 words at the end. Should be roughly, rough draft of like an article. The 3 participants with the highest word count at the end will receive prizes. So there's something in it besides completing the project. So there's a sheet on the back with a QR code that you can use to sign up. We also sent an email that you can search for. And so now, Dr. Jenna Rolfs and Dr. Thomas Colletti are both professors in our DMSC program. Dr. Rolfs is a graduate of Butler University's PA Medicine program and has a clinical background in emergency medicine, general surgery, and primary care. She also has a DMSC from University of Lynchburg and an MBA from Butler. She serves as Dean for our School of Medicine and Health Sciences and Program Director for the Doctor of Medical Science program. She also serves as President of the Virginia Academy of PA Board of Directors. Dr. Colletti trained at the U.S. Public Health Service PA program and also holds a Doctor of Medical Science from A.T. Still University. He is a professor in our DMSC program teaching evidence-based medicine and medical writing. He's also a member of the International Academy of PA Educators, where they are mapping PA curricula from around the world. In today's talk, he and Dr. Ross will show us research looking at the career effects of the DMSC degree on alumni and studying the importance of that program for practicing PAs. So please join me in welcoming our colleagues.
Thank you, Robin and the Research Center. So Dr. Colletti and I are tag teaming this presentation today, and my part is first. So thank you all again for letting us be part of the Research Center presentation series this year. I'm gonna scroll really far. What do I have to? Maybe. Rolling on the mouse. It's probably user error. Oh, there it goes. Just a little touch. Okay. All right. So I just wanted to start off the presentation with a raise of hands. Who has ever been seen by a PA, a physician assistant, physician associate? Yes. That's amazing. What an awesome start to the day. So the physician assistant, now our name changes going to physician associate profession is a fairly new profession, but we definitely have a huge impact in the healthcare sector. So the DMSC program, the first matriculation of the class was back in 2017. And we have now 8 years of data from our alumni with approximately 2,000 alumni. And we are now starting to think and look at the survey data and determine, why does this data matter? What can we do with this data? Well, again, the University of Lynchburg DMSC program was the first civilian doctorate for PAs, with the first class to matriculate in 2017. How many programs are there now? Let's have some guesses from the audience. And if you know this answer, do not guess. You didn't know you're going to have active participation at lunchtime Research Center presentation series, did you? Just throw some guesses out there.
18.
18, 10, love it.
100.
There are 31 programs and counting. And I will say, when the program first started, there were a few that gently followed quickly after, like LMU, A.T. Still, Butler, SIU, Southern Illinois, University Carbondale. But now, every time our DMSC and some of the programs are DMS programs, we meet as a consortium. Every time we start meeting, there's new people on there, new emerging programs, program directors that have been hired but are still startups on these programs, and they're coming to us and the consortium for advice, for feedback. How did you launch a program at your university? So when we started meeting as a consortium and gathering data, Lynchburg has had a huge impact on that data because we have the most graduates out of all the 31 programs. The other good and bad part about being the first DMSC program is we're the first and the largest, but now we have to start and continue to make strategic decisions on curriculum, outreach, and marketing. So our rich alumni base helps us navigate the quickly changing landscape of our post-professional doctoral education programs, because as you know, DMSC programs that are starting now, they research and they analyze the programs that have been successful, but they also determine what things like, oh, I'm going to do this better, or I'm going to do this, and so that way we can continue to be competitive in the market. So this is why we really thought this data and this research was important. Gosh, I'm struggling with this thing. All right, so to summarize, the PA profession was created 57 years ago at Duke University, and the profession has advanced from awarding a certificate to a bachelor's, and ultimately in 2020, our accreditation body, ARC-PA, required all programs to be a master's degree, which is considered right now our terminal degree. There are 310 master's PA programs and counting, and though there's a lot on the docket for that as well. So to get us started, let's just review a little bit of history around the physician associate profession. So again, the first program was at Duke University in 1967. And as you can see throughout the history timeline, the profession has evolved rapidly to the point where now, originally we were considered being supervised by a physician, and now as we go on, we really we don't like the term supervise. We consider that we collaborate with our healthcare colleagues, but it has evolved so much over the years that now there are states that are actually considering PAs and have legislation change that allows PAs to be autonomous. So North Dakota, Utah, and Wyoming have recently eliminated the legal requirements for a specific relationship between a PA and a physician or any other healthcare provider. Who wants to know about Virginia, the state? Yay! I'm so glad you asked. So the state of Virginia, as the Virginia Academy of PAs, our board of directors, and we have lots of people that have served on the board and have moved for the profession in this room, as well as current individuals on the board, is moving towards autonomous practice in Virginia. It'll be about a 2-year kind of projection, where this is the first year that we're starting with legislation. So we have partnered, and the Medical Society of Virginia, our physician colleagues, is partnering with us to move this legislation forward, and we are going through the right process. So we're going through the Department of Health Professions to do kind of a survey or a review on what is considered the number of clinical hours you need to practice as any clinician to be considered competent and confident in your practice and your skills to be autonomous in practice. And then that will happen this year, and then the following year we'll carry the legislation forward with our MSB colleagues. So again, we're really excited about this. So Virginia will be at the forefront of moving the profession forward, as we already have. What PA in Virginia can already practice autonomously? Our PA colleagues can help with this if you want. Medical examiners. So your medical examiners, if you're a PA, you can practice autonomously, which means you don't have to be tied to a physician in the state of Virginia, which is a really huge thing because that eliminates a lot of barriers, practice agreements, people having to sign off your charts. All right. So I love to to kind of explain the PA profession so you all know like why we did this survey, why we are doing this research, and why this data is so important to our profession. So has anybody said a PA and has called us physician's assistants with apostrophe S? Don't do it, don't do it. We hear that and we cringe. Our hair sticks up on our neck, like everything, because we are not a possession. We are not owned by anyone. We are our own entity, our own profession. We have our own patient panel. So again, a lot of us, we won't even introduce ourselves as physician assistant. We'll come and say, hi, I'm Jenna. I'm a PA in clinical practice. And if they ask us what a PA means, then we'll explain what a physician assistant is, because we've never felt that our name really explains what we do as a clinician. What about mid-level? Who has ever called us mid-level? No one? I love this. So mid-level, you won't hear it as much anymore, but typically we were called mid-level providers. Well, let's be honest, as a patient, would you ever want to go and see somebody who was called a mid-level provider? Nothing we do as physician assistants, PAs, is mid-level care, so why would you want your provider to be called mid-level? Oh, you're a physician assistant? Tell me more. Why didn't you finish med school? So we have heard this in the past too. Again, it's starting to evolve as we become progressive in our profession, we publish in our profession, we become known, we start speaking at large national state conferences, and it is really hard, honestly, to get into PA school. And a lot of people, no one goes to PA school if they wanted to go to med school. We tell people, if you're interviewing for PA school, it's not because you couldn't get into med school. If anything, it's harder to get into PA school now than med school. It's harder once after you get into med school to find that fellowship or residency. And then physician extenders. We definitely are not physician extenders. We have our own patient panels. We're able to see patients ourselves, have our own clinics. It's amazing to see what we're doing. There are rural hospital systems that there'll only be PAs in the hospitals at night. They do all the critical care. There may be a physician on call, but it's really the PAs that are running the hospitals. So, big X. If you learned anything today, don't call us physician's assistants, don't call us mid-levels, physician extenders. We're PAs, we're part of the healthcare team, and we love to work collaboratively with all of our NPs, midwifery, physicians, DOs, MD colleagues. Okay, so how did we get here, and really why does it matter? Well, ultimately, at the very end of the day, it's about improving patient outcomes, right? It's about the impact we can have on the healthcare system. We can eliminate barriers, break down barriers, and really provide that increased access to care, which, as we all know, healthcare is a crisis in the United States and beyond, and that something's going to have to happen because there are more and more people going without primary care. So we're truly at a crossroad in our current profession. So as we talked about, there's 310 master's programs in the United States. There's 31 developed and or developing DMSC programs. That hill has gone so high. Like typically there were about 5 or 6 DMSC, DMS programs, and now every single week I actually see a lot of our alumni posting on LinkedIn, celebrating, which is amazing, that they are becoming the inaugural program director for a new and up-and-coming and developing DMSC program. So we're really at a crossroads as a profession to decide, are we going to go to an entry-level doctorate program, or are we going to stay the master's as our terminal degree with a post-professional DMSC, DMS? And just for working numbers, there's about 180,000 PAs. About 9,000 to 10,000 PAs graduate every year from our master's programs, but there's only about 3 to 4% of PAs that are doctorally trained. So the University of Lynchburg again began accepting students back in 2017 with an inaugural cohort, and then it really just has exponentially grown, and we typically enroll about 350 students annually. This is where our study for our alumni really comes in, is really important for the future of the PA profession and doctoral education of PAs. So our academic calendar, just for some background before we get into our data, is we enroll 5 times a year: January, March, June, August, and October. And then most of our students can complete the program in 12 months, though we're really flexible and can extend their plan of study if needed, and each term is 8 weeks. This is our enrollment by state. So we recently really kind of did a deep dive into how many enrollees are we getting per state. So we really have reached every state except for 4. And our high enrollments is definitely Virginia, but Texas, New York, North Carolina, Georgia, Florida, and California. And this is really helpful to know because we can then strategically start marketing to the states that we're not getting students from, as well as continuing to provide that impact and support to the states that really are we're really enrolling a lot of students from. We have 6 concentrations now. So when the program first started, it was 1 concentration, the advanced professional practice concentration. Because we've gotten feedback from alumni throughout the years who state the advanced professional practice concentration is more for clinically based PAs who are practicing clinically about 100% of their time. We have a lot of PAs now entering into administrative roles. So they're 100% administrative roles, or they're non-clinical roles. They're medical science liaisons. So they really needed concentrations that would benefit them. That's how our administrative medicine concentration was born. That's how our medical education concentration was born, because we had PAs that are educators and they wanted to go up for promotion and tenure, and they needed that terminal doctoral degree that was recognized by their institution. Our emergency management global health concentration was born because we have a lot of students that want to do international humanitarian service. And then our most recent is our behavioral medicine and addiction medicine concentration, and that's truly responding to the need of our healthcare system today and the crises we're in. The very interesting thing is sorry, I'm gonna get ahead of myself, is that our APP concentration, which is our clinical-based concentration, is still the most represented concentration. It has the most enrollment. And this really defies a misperception in our PA profession and the external lens of the community looking in on the evolution of the PA profession right now, is because a lot of people will say, well, why do I need this? Why do I need a DMSC or DMS? Because I'm going to practice clinically my whole life. Well, I won't tell all of Dr. Kilgore's presentation at his research center that he's presenting in the spring, but we also have published an article on the misconceptions of the PA profession, and this is one of them. There's a lot of things that people are doing clinically, even just becoming better leaders at the bedside by getting their DMSC degree. We also offer various certificate programs, so a lot of individuals say, I'm 100% practicing clinically right now, but maybe I want to do education in the future, so they'll add on the medical education certificate so they have that extra advantage when they apply for that faculty role, because they are starting to understand the accreditation process and what it means to be and what it takes to be a faculty member in a PA program. And then these are just a list of our certificate programs. And now I'm going to turn over the presentation to my colleague, Dr. Colletti.
Thank you. And welcome, glad to be here. And that was a great introduction to the PA profession. I think that was really needed to be able to get that out there and explain exactly what PAs are. I've been a PA for over 40 years. And when I first started, I finished the PA program and I walked downtown, and I met somebody I knew, and I said, I just graduated from the PA program. I said, oh, that's great, police academy. We need more police officers. And the name that used to bother me the most was physician extender. That sounds like hamburger helper. We're not an extender. It took a while for us to get to that point where we are PAs and we're practicing. 2 weeks ago, we had the International Academy of PAs educators here. And we had a conference with people from Africa, Asia, India, Malaysia, and Australia. People from all over came and gave talks. And so it was a great opportunity to talk about the PA profession. And I'm going to do a little bit of a review of the statistics from our survey. And our colleague, Dr. Kilgore, actually did the deep dive into the statistics and pulled out all this and created these graphs, so we appreciate that quite a bit. So I'm not a stats guy, I'm not a data guy. One of my favorite Mark Twain quotes is, there's statistics, there's lies, damn lies, and statistics. So you can take it with a grain of salt which way you want to go with that. Okay, so the purpose of this survey was to gather data from graduates of the University of Lynchburg's DMSC program that reflects upon the DMSC curriculum and the degree's impact on alumni careers. So we use this also to look at our curriculum, make sure we have to make any adjustments, and wanted to know if it did impact their careers. So we'll go into that a little bit more. And this was approved by the IRB, our survey, to publish it. And, hello. So besides myself, Dr. Kilgore, as I said, we led this survey, and our team consisted of Dr. Rogers, Dr. Wolfs, and Dr. Welsh. And we had a whole bunch of other folks that were working with us also, so this is an incomplete list. Okay. There we go. Okay, so the 7-year survey was released in September 2023, collected data from classes from, this is actually should be 2017 through 2023. And the survey was sent to 1,300 alumni, and we received 250 responses, which resulted in a 19% response rate, which is not the greatest response rate, but it's kind of hard. We're sending it to their DMSC email, and a lot of folks are probably just not looking at their old DMSC email. The survey now is going to be deployed each year in September. And the most recent 1-year survey was deployed September 1st and closed on September 30th this year. And the survey was sent to 340 alumni, and we received 70 responses, and that resulted in a 21% response rate. So I think the ones that were not out quite as long had a little bit more interest in maintaining their UL email. And the survey received face validation from experts in our department. And the survey was delivered on Google Docs platform, and it consisted of 45 questions with sections consisting of demographics, compensation, promotion, career goals, and reason for pursuing the DMSC degree. And it was a mixed method survey with some sections having multiple choice questions, some with fill in the blanks, some with the Likert scales. So demographics, the age distribution. From both of these surveys, it looks like most of the alumni are between the ages of 30 and 59. And a smattering of older folks over 60, like myself. And so the younger folks, we're going to hopefully get more folks coming in initially right after their master's degree. And demographics, racial and ethnic. So in both the 7-year and the 1-year, the white was about 70 to 73%, black around 11, and 1 year, 7%. So hopefully we get a little bit more diversity. We're looking for that, and we're hopefully trying to recruit a more diverse program. And gender. So the 7-year male about 51%, whereas male in the 1 year about 35%. And that really mimics the AAPA annual survey that about 66% of PAs now practicing are female and about 33% are male. And that holds true into medical school also. A lot more females going into medical school medicine. So we're kind of par with that. And we have a great military cadre. We have about 10% active duty, and some of them are in Japan. I have some in Afghanistan. And one of my favorite pictures is one of my students in Afghanistan in Kandahar, and he's sitting on a gasoline tank, and he's got his laptop on his lap, and he's doing his homework. So they are motivated, and they get out there, and we have a number of international students coming in with us also. So veterans 7%, and retired about 6%, and National Guard, of course. One of my students called last week and said, I can't do my paper this week because I'm in the Florida National Guard and I've been deployed because of the hurricane. And so we're very flexible. We're trying to get their work done. Additional compensation for DMSC graduates. So percentage of graduates who indicated receiving additional compensation within 1 to 5 years of completion of the degree was 43%. And the percentage of graduates reporting completion of the degree actually contributed to the additional compensation was 80%. And it was self-reported by survey respondents that 66% of the employers stated that the DMSC degree was indeed a contributing factor to their additional compensation. Therefore, earning a DMSC degree from Lynchburg has shown to lead to an increase in compensation for many of the graduates. And promotions reported by DMSC graduates in the 7-year data. Percentage of survey respondents who, upon completion of their degree, reported within 1 to 5 years of having received a promotion was 36.5%. And the percentage of survey respondents who indicated that earning the DMSC degree contributed to their promotion was 76%. So it really is showing that the DMSC degree is a meaningful addition to the master's degree training. So therefore, earning a DMSC degree from Lynchburg can contribute to the opportunity for promotions and advancement within organizations in the healthcare system. Changes in leadership style. The percentage of participants who reported a change in their leadership style was 91%. And one of our courses is organizational behavior and leadership. And the percentage of participants who self-reported a job review from their bosses commending their leadership was 54%. And the percentage of participants who attributed that the program prepared them for leadership positions was 77%. So those courses that we're teaching in the Doctor of Medical Science are really paying off as far as their careers are going. So therefore, earning a DMSC degree from Lynchburg can contribute to leadership development and new leadership positions. And reasons for PAs to pursue the DMSC degree. So primary reason was professional development in both the 7-year and the 1-year cadre. Career advancement was also very important, leadership development, and a change in career that mandated having a doctoral degree to be able to move into that new career position. So this is our publication, Characteristics and Career Effect on PA Graduates of the Doctor of Medical Science program. And it is in print right now. Going to be released any day electronically. We've been kind of milking the system to try and get it out in a in a publication form also. One of the things with the AAPA, or JAPA, Journal of American Academy of Physician Assistants, is that they're inundated with articles. And a lot of that's coming from us, not just us, but all the DMSC programs, because they all have capstone projects like ours, writing a manuscript and submitting it. And a lot of them want to submit it to the primary journal for PAs, JAPA. And so they're being inundated. So it's taking a little time for this to come out in print. But within the next week or so, we'll have a DOI for it to be able to be published online.
So the future of the PA profession. So lately there's been a lot of talk about the accrediting body for the master's programs, the 310 master's program, wanting to accredit our DMSC, DMS programs. And what would this mean? Well, in the consortium, a majority of us do not want this. Why? Because we are regionally accredited by our regional accreditor, so SACS is our regional accreditor. The DMSC is a post-professional doctoral degree. This doesn't add anything to PAs where they have to sit for a licensure exam. So anything that the accreditation body right now could add value to, our SACS is already doing it. So we just feel like this would be an additional cost, additional expense, where frankly we feel like the train has already left the station. We have a credible product. We have 2,000 alumni that have graduated, and there's multiple programs that have already developed or are developing because they see the value of this post-professional doctoral degree. Now, there may be a time where the master's program will go to an entry-level doctoral degree for PAs, but that is two separate entities. But that is a huge talk right now between our 4 national organizations within the PA profession. So our 4 orgs are ARC-PA, NCCPA, AAPA, and PAEA. And there is much discussion around this, but ultimately our post-professional DMSC, DMS programs are not favoring wanting to be accredited by our current accrediting body that credits our master's programs. Additionally, the accrediting body also wants to kind of standardize the curriculums, and if you look at the various 31 programs that are developing or have developed, there's a lot of diversity, which is really what people are wanting. When we talk to our alumni and other individuals from various programs, they want the diversity in these post-professional doctoral degrees because that's what they're looking for. When they choose their program and their university that they're going to obtain their DMS or DMSC from, they are looking for a curriculum that fits their needs. So they're looking for that emergency management and global health concentration or the medical education concentration because they want to become faculty someday, or they want to do humanitarian medical mission work. And standardizing the degree with a program accrediting body right now would cause a lot of standardization amongst all the programs and also limit international student acceptance. And that's something that we already accept international students, so we also don't want to limit being able to extend internationally to the DMSC program. All right. So ultimately, as we continue to further our research and gather more data and do more surveys with our alumni, we have found that the PA profession is recognized as an integral part of the healthcare team. The PA doctorate provides the academic rank and title the profession deserves for completing the number of postgraduate credits required to be a PA. So typically, another audience participation moment, what is a typical master's credit load to get a master's degree? 36-ish, right? What is the typical credit load for a master's of PA medicine program anywhere?
28.
Around 128. Or if somebody says you can only do so many credits, and like our university is 101 credits because I've been told that it was going to be like 140, but it needed to go back to 101. So again, we buy credit load have earned that doctorate degree, because if you do a PhD and you have a bachelor's before you enter your PhD, it's pretty equivocal to the 100 credit loads. Well, the master's already is, we are 100 or over 100 credits for our master's degree, which is really interesting because like when I went to PA school, I didn't even realize that. Like I was like, I'm gonna be a PA, like yay, I'm so excited. I had no idea that I was doing a master's degree that was 3 times the typical master's degree credit load. But it's our accrediting body right now says that they'll only award a master's degree, so that's the only master's degree you can award as an institution. The doctorate has really created that parity for us within our healthcare team. So all of our healthcare colleagues have a doctoral degree in their academic discipline. We as PAs didn't have that prior to the DMSC. So our NP colleagues, our DNPs, our PT colleagues, our DPTs, audiologists have a doctoral degree. Everyone has a doctoral degree, so this really helps us create that parity with our healthcare team, which is nice when you have a seat at the table or you're in a meeting. Like everybody has that same level of kind of credibility or credential behind their name too. Again, the PA doctorate opens possibilities for advancing careers for PAs, not solely as clinicians, but as upper level administrators, researchers, and educators. So we have had a lot of success stories in our DMSC program with all our graduates. Some of the ones that are really striking to me is we currently have an alumni who serves as a chief executive officer at a hospital. We have several alumni that are really high-level assistant vice presidents at large hospital systems, or they're system-level directors at various hospital systems. They're medical science liaison, which they're very high up in that director role as we call them MSLs. So they're coming back and saying, the reason I got this position, or I was even eligible to apply for this position, was because of the doctoral degree. Having that credential behind my name, put my resume at the top of the stack, I got the interview, and then it was up to me, right? Like anybody can have a credential behind their name, but then it's up to the person to use their skills that they learn and their leadership skills to really discuss what they can do, really sell their self in their interview and get that position. But the degree helped them get to that interview stage. The postgraduate doctorate for PAs is an attempt really, again, like we said, to gain that parity with other APPs and for the recognition of deserving a seat in that boardroom. And then ultimately, we really want to advance the PA profession with the addition of the professional doctorate. So a lot of people will kind of say like, oh my gosh, they're really like other programs that are developing, that looks really familiar, that looks really similar to like your curriculum. And honestly, it's all about advancing the profession. So it's a really good thing for our profession overall. So we are really excited to see leaders emerging after they get their DMSC degrees and ultimately really becoming change agents. And I kind of wanted to close with just a little reflection. Like as we were doing this presentation, working on this presentation, I was really kind of reflecting about my time as a PA. And I just remember when I first started as a PA, I felt like I was very innocent. I got a job in emergency medicine. I was going back home to Illinois, so it was in the southern suburbs of Chicago. And I was just really innocent on what I was gonna do and in the ER. And ultimately, I grew as a professional because of the experiences, but I also learned that some of the things that I encountered or the obstacles I faced during my full-time clinical career really shaped me in my work ethic and my leadership skills today. Because I would remember being kind of frustrated after, and I know a lot of people in this room can relate to this, being frustrated working on a shift with my probably supervising physician at that time, but I won't use that word anymore, to be my collaborating physician currently in the state of Virginia at the time. And we would be in triage or fast track, and we would be working together, but ultimately there would be a nice line of charts, right? And typically you just pick the chart at the top, right? Because that's what you do, because that's the next person that would be seen. Well, sometimes you'd work with people who would cherry pick. And so all of a sudden, I would have one of my physician colleagues cherry pick the toe pain. The toe pain. Like, come on. Like, you're a physician, you went to undergrad for 4 years, medical school for 4 years, probably did a residency and maybe a fellowship, and then I got the 89-year-old male chest pain with 10 family members in the trauma room, and I had to deal with all of it. It's a true story. Everybody can tell you that's a true story. And ultimately, I would call home on my ride, because I had a 45-minute drive home every day, and I would talk to my husband and vent about it. But then ultimately, I look back, and it really shaped me as a PA, because I had to do it. Like, it didn't matter, because, at that time, like, that was how we practiced, and I had to do it. And I became a more competent PA. Out of it, I became more confident. I developed leadership skills. I developed having crucial conversations, and really navigating a healthcare industry that I wasn't as familiar with as a new PA. And ultimately, it just, like, reflecting on this, it really, like, helped me understand, okay, this post-professional doctorate degree is actually just adding really the credential and breaking down barriers and advancing with our legislation. It's really bringing legislation to the forefront of what we're already doing as PAs. Like, most rural PAs are already working autonomously or working very independently as PAs, and there may not be even a physician on site. So now breaking down barriers, creating legislation, passing legislation that allows us to eliminate the practice agreement and eliminate that collaborating physician is truly just matching what our healthcare industry is already asking us to do as PAs. And now we'll take any questions.
I feel the same way. I have memories of, after being in clinic for 10 years, I got a new collaborating physician. And I said to him, well, if I see somebody who's a little bit unusual, I'm not really quite sure, I'll refer him to you. And he says, no, don't you dare do that. If you don't know what it is, I'm not going to know what it is either. So send them to someone smarter than both of us. So you develop a good give and take. And in orthopedics, I ran the orthopedic urgent care by myself. Nobody was around except for the patients and me and the nurse. And after a while, you become very comfortable making those decisions. And then the physician would call me and say, I don't really feel like going there tonight, but there's a dislocated elbow in the ER. Could you please go take care of that for me? Oh, yeah, I've never relocated an elbow before, but I'll go do it. So you take on the brunt of anything that comes, and little by little you get used to it. Questions?
Comments? Who learned more about, share.
I actually have a question that's going to display my ignorance, so this row here, please. Because I'm a humanities person and not from the sciences. So I thank you both for your presentation today, because honestly, I've learned more about the PA and DMSC program today in this one presentation than, ever since the program started here at the university, so I thank you for that. What I find myself wondering, because I don't know the difference between a PA and a nurse practitioner, I have a little bit of understanding the difference between a physician and those two. So if you were advising an undergraduate who is starting out, a freshman, sophomore, and they're sort of looking ahead at a career track, I'm familiar with the attitude that you talk about with the X. The PAs are, if you can't get I'm sorry to say this, but like if you can't get a real physician, then you're stuck with the PA. I understand that mentality from the past. So if you're looking at they're just different career tracks, how would you guide a young person who's thinking, do I go to medical school and become a physician? Do I go to PA school? In other words, there's got to be, sitting here thinking, there's got to be something at the end of the road that you're looking at wanting to do as a PA that's different from what you would be looking to do as a physician. And I'm wondering, what is that?
You want me to take that? So the nurse practitioners are nurses, and they train in the nursing model. PAs are clinicians, and they train in the physician model, medical model. So there's a big difference in the undergraduate or the beginning of the programs. I was a founding director of a Campbell University PA program, and I actually hired a nurse practitioner to come in and teach women's health. And after about 2 months, she knocked on my door, came in the office. She said, "I can't believe how much better the PAs are prepared than the nurse practitioners that I went to school with." That being said, when I worked in the ER, there was one nurse practitioner in the ER. I let her do anything to save my life because she was excellent. And it has a lot to do with maturity and experience. So if you're there doing it every day for years, you're going to pull up some experience.
I'll add a little bit onto that. Also, we recently had a fireside chat with Dr. Terry Davis, who's a PA, but then she went back to become an MD. And at the end of the chat, she did a lot of humanitarian work. She said, "Nothing that I do today as like a primary care physician there's nothing that I do that a PA can't do." And she says, and she is still a PA, but she's also an MD. So I think in those fields, in primary care, internal medicine, pediatrics, urgent care, emergency medicine, we are hand in hand on skill set. But I also worked in general surgery. I would never be able to, take out somebody's gallbladder by myself. So there is that value of the healthcare team, and there's a need for every single individual on the healthcare team. Also, for PAs and NPs, we can flex a lot. We can pivot. I started in emergency medicine, and then I moved to South Carolina, and there was a general surgery opportunity open, so I was able to apply to that position. Your physician colleagues are not able to change specialties unless they went back and did another, like a residency. So there's not as much flexibility, which you see a lot of females in the PA profession. It's a high percentage of females, and I think I can speak for myself. I chose PA for the flexibility, but it also created a better kind of, I call it work-life blend, and I wasn't, absolutely stuck having to do ER my whole life if I didn't want to do it.
Yeah, I started off in pediatrics, and I got a little tired of screaming kids, and so then I went into emergency medicine. Then I got a little tired of screaming adults, and then I went into urgent care, which was a little bit more reasonable, and then I went to orthopedics, and everybody was asleep, so it was a lot easier to do the work. So yes, the flexibility is really interesting. And then I segued into academia, and I've been doing academia now for the last 10 years, 20 years.
I see comments that are coming up from people participating online. Are those going to be available on the video that we can watch later?
They're just supporting what they were saying. The degree flexibility and the standardized education allow for us to switch tracks essentially as we can.
Did that help answer your question, though, a little bit?
Yeah, I'm still wanting just a little bit more, though, for why you would choose PA instead of medical school, or vice versa.
And I think it depends on specialty also. Primary care, as Jenna was saying, is kind of equitable between the two professions. But if you wanted to be an obstetrician, or you want to be an ENT surgeon, then you really need to go to medical school, because then you have to do a 3 to 6 year residency after medical school. And so it really depends on where you want to go with the career. If you want to do primary care medicine, you can be a PA, or you can be an MD and do primary care, but you still have to do that 3-year residency as a MD.
And PAs, NPs, we're not required to do a residency or anything, so 27 months, you're done, you graduate, you have a great mentorship with the job that you take, and you're making your salary right off. So that were a residency, 6 years, it takes a little bit longer to get in that, with all the kind of the debt too. Does that help? Okay.
always been curious about the naming of the degree. Was DMSC, was that an established doctorate name outside of PA? Was there a reason we went with that as opposed to like a PhD in PA medicine? I've always just been kind of curious about the establishing the name of the degree.
Dr.
Would our
Welch.
founder want to?
The story will not surprise you. So in Australia, after you finish medical school and residency, the Doctor of Medical Science is the highest level of education that they could obtain. So it was above being a physician.
Interesting. Strategic.
See how that works?
Yeah, I see. Okay. Makes sense.
So would that be more equivalent to like a MD PhD program that's more common in the United States?
So in Australia, they are considered not qualified to do research with an MD. They must go on for additional training. So the DMSC would be their version.
So they would do DMSC instead of PhD, correct?
In Ethiopia, they're called clinical officers, and they have a PA degree, but they call clinical officers, and they're trained to do cesarean sections by themselves. They do the anesthesia, they do the surgery, and I was shocked when I heard that from my colleagues over in Ethiopia. But there's a big division depending on what that country needs, and then it kind of branches out from there.
And I also, not to speak for him, but one of our adjunct faculty, Dr. Travis Kaufman, is in the U.S. Army. And what he does in the field as a PA, we would not be allowed to do as civilians as PAs. So it's really interesting to hear because it's just, I mean, they honestly have free reign because they're in the field, it's an acute emergent setting, and they're, doing lots of things that we just wouldn't be able to do as civilian PAs within our scope of practice. So.
How intentional do you all have to be to combat the misperceptions that you were talking about before?
All the time.
It's a lot different now. When I started, like I said, nobody knew what a PA was. And now, talking with my primary care physician, and we were talking a little bit, and I said, so who do you go to? He says, oh, I have a PA, he takes care of me. There's a wide variation now. Everybody knows what a PA is. Like when she asked the question, how many of you have been seen by a PA? Most people know. So you used to be, I'd walk in the room, you'd have to explain it. I'm a PA, what is that? Well, it's 2 years medical school rather than 4. And when are you going to become a doctor? Well, I'm not going to become a doctor. That kind of has gone away. It's still out there in public, but it's not quite as extreme as it used to be, luckily. Anybody else? Yes?
Thank you for a wonderful presentation. I'll echo Dr. Coleman's comment. I learned a lot about your field. Question, how much preventative health care is a part of PA, right? Health counseling and health behaviors. Is that a part of that curriculum?
Yes, it is. We have some expert faculty in the audience that are actually teaching if they want to add in. I'm kind of looking at you, Dr. Dellis and Dr. Castro, but if you want to add, not to call you out, but yes, it's part of our standards, our PA program standards, so that there's certain things that must be taught in every single PA program. All 310 programs have to show that they teach these various standards, and preventative care is part of it. It's just how we tell our accrediting body how we're teaching it, and then they're going to hold us to how we tell them that we're teaching it, but ultimately it's taught and students are tested on it.
So I bring that up because I work kind of allied health, and preventative care is a really growing area in healthcare, right? We're getting away from the medical model and the drug treatment to treat, right? And I see your field as maybe being a little more nimble to be able to address that emerging need in med schools. They're very dogmatic on a lot of that, right? Surgery, surgeons taught to basically treat with surgery, right? So do you feel that as a part of the growth too, is that you can be more nimble to meet this kind of societal and cultural change perspective?
And that varies with each individual PA where they want to go. Some people want to work in the ER and they're going to be there for 30 years. Others, like me, get a little itchy. I got to change fields a couple of times. And that adds to some of that experience that you have also. I know when I was in orthopedics also, when a physician would come over, a surgeon would come over and said, I got a patient who's got a tick on it. Can you come over and take a look? I don't know what the hell to do with this thing. So yeah, we have a lot of that kind of common sense information that if you're trained as a surgeon, that's what you're doing.
I think it also depends on the need of the community you're in. Most primary care practices right now are so inundated with appointments that it's hard to get a primary care appointment with a PA, NP physician for like 90 days. So their expectation in those clinics is whether you're a PA, NP physician, you're seeing patients every 15 minutes. If it's a patient, an established patient, or a new patient, you're seeing them maybe every 30 minutes. So I really think it probably depends on the need. I know when I interviewed for PA school, it was all about, I wouldn't say this now, please, I would not say this now, but I know I did say this in my interview, like, I want to be a PA because I want to be able to spend more time with patients and be able to take time and talk to them. And obviously I still want to do that, but right now, the way our healthcare system is, we're on like RVUs and paint on how we have to see patients so many patients per hour and so many patients per day, and that it doesn't change whether you're a PA, NP, or physician because the need is there, which is unfortunate. Obviously, like we want to be able to spend time, which is honestly why I love part of our master's program. Our faculty go down to the Free Clinic of Central Virginia, and if we need to spend 2 hours with a patient down there, we can, because they're there for care and there's no time limit because it's free care for them.
Anybody else?
Thank you all.